It's time to start session. This is, I think, only for the mitral intervention. So keynote session, Cutting Edge Innovations in Valve Therapeutics 2. I'm Jung-Sun Kim, several Aspirant University. Co-chair is Shih-Hsien from Taiwan. And I also introduce a panelist, Boron, Cheng, Hosoba, Byung-Hee, Hwang, Takashi, Matsumoto, Krissada, Meemook, Kyung, Kenso, and SEOUL. At first, I would like to introduce first speaker, Eberhard Grube from Germany. He will talk out-of-box solution for mitral valve repair replacement. Eberhard, please.
Yeah. Thank you very much for your kind introduction. My role today here is, after talking a lot about mitral valves, out-of-the-box solution for mitral valve repair and replacement. Again, my disclosure. So really nothing has changed and should not change. The 20-year-old debate on general treatment goals for mitral regurgitation. That is, first, reducing mitral regurgitation to minimal. Second, treating early to allow the heart to remodel. And third, keep future treatment options open, particularly for younger patients. We do have surgery, very successful treatment, and they could tell us what the fundamental principles of surgical MV repair and good long-term outcomes is all about. Number one, restoring or preserving full leaflet mobility. Second, provide a large surface of leaflet coaptation. And three, remodel and stabilize the mitral annulus. We have to put this into perspective because we are looking into out-of-the-box solutions. Also, predictors for good long-term outcome is not something that we have to invent. It is something that is there simply looking at surgery. Number one, no residual MR and ring annuloplasty. We do know that surgery and TEER are the standard of care for low-risk patients, surgery, and for TEER anatomies that are suitable for TEER, then TEER is the gold standard. Only for prohibitively complex TEER anatomy and unsuitable for surgery, then transcatheter mitral valve replacement kicks in. So if we look at the landmark trial of TEER, a beautiful comment of Dr. Michael Mack, is COAPT a rising tide that floats all boats, or will it only float one boat? The investigators of COAPT actually, after 5 years, suggested the findings, as you recall, emphasize the need for further therapies to address remaining MR patients and underlying left ventricular dysfunction in this high-risk population. The key question still remains: have we achieved the goal of eliminating MR with present transcatheter approaches? Is reduction of MR alone sufficient to achieve our clinical goals? That is, positive left ventricular remodeling. So here are some of the out-of-the-box solutions to treat mitral regurgitation: hemivalves or posterior leaflet augmentation, Sutra, mitral butterfly, Carline, Polaris, and Half Moon. Translateral approaches to intend to enhance coaptation or replace the posterior leaflet. Half Moon is a coaptation augmentation device that's designed to eliminate regurgitation by a contoured EPTFE baffle which fills the regurgitant orifice and hits the anterior leaflet. This little video shows basically what it is supposed to be doing. You augment the posterior leaflet, and the coaptation with the anterior leaflet is actually happening. The first clinical use has been reported in 2021. You can see the pre-implant images and the post-implant images. Quite successful at this very first case. Then we have the Sutra approach. It is a 3-leaflet hemivalve approach. You can see the native mitral valve, posterior leaflets P1, P2, P3, has been replaced by the Sutra tri-leaflet posterior leaflet. And you can see here better coaptation with the anterior leaflet. Here you see the early preclinical results in 40 CT from an animal, and you can see where the arrow is. The coaptation with the anterior leaflet is improved and increased. Another interesting approach is the Polaris approach, posterior leaflet restoration. This is the device. It is active and consisting of the frame, a nitinol frame, and then you can see the ACE, adaptive coaptation element with bovine pericardium. On the right side, you can see in blue the frame, and in red, the ACE device, basically doing the same thing, coapting with the anterior leaflet. The leaflet replacement and the procedure is fairly simple. As you can see, it is approached by something that we already know, basically transeptal approach. You locate the posterior annulus and you engage the central screw, then followed by two lateral secondary screws, and then you test the device regarding the gradient and the degree of mitral regurgitation. And this is, until here, you can actually retrieve the device and either abandon or change. From that point on, there's a point of no return, and then you have to deploy the device. This is the first generation that we did in 2019 in Germany. You can see the posterior leaflet, the screws, and also the left ventricular angiogram, implant deployment with good acute result. The company changed the devices several times, and here we have the second generation, first in human, the M-Raise device in May 2023 in Sao Paulo, and you can see 1 year follow-up and 2 year follow-up with a revised design, quite interesting and very successful. Also comparing it with the G4 mitral clip results compares very favorably. And last but not least, the transcatheter cardiac leaflet enhancer, or the Carlin device. The Carlin device is designated to achieve wide and deep systolic coaptation at the site of regurgitation with a single implant. You look at echo, where the regurgitation orifice is, where the leak is, and then you can move the little device exactly to that site. As you can see here, it is a very small device that is clipped to the posterior leaflet. Basically, the delivery is simple and intuitive and parallels procedural steps used in current commercial devices, transeptal crossing, steering into the left atrium, and then go perpendicular, something that we all are used to, and then cross the valve, grasp the leaflet, and then basically access the coaptation release, and then deploy and look at the final result. Quite intuitive. So it is designed to correct functional MR in varied anatomies. Ventricular FMR with a central jet, then ventricular MR with a commissural jet or lateral jet, and also, importantly, atrial FMR with a wide jet. Very interesting and very successful early human experience with this device. As you can see here, baseline TE, functional mitral regurgitation, and then persistent reduction at 30 days post-procedure without diastolic inflow. So early results and early clinical trials is underway. Quite interesting, and it leads to persistent reduction in FMR, at least in the early results. So basically, if we look at the potential alternative to TEER and TMVR, we know the scenario of TEER and of the valves, and then we look at the complex and non-complex solutions, basically TEER for the non-complex, reaching, depending on the experience of the site, to the more complex lesions. If the lesions are too complex, then, as we discussed previously, TMVR is the choice, however, with its own limitations. Then we can look at the hemi-valve, which actually has a high inclusion rate, more than 70%, and then leaving other therapy options actually open. So quite interesting. It might be filling the gap. Let us be honest, the basic premise of transcatheter innovations, you cannot discover new oceans unless you have the courage to lose sight of the shores, meaning we have to get out of the trail of surgery and find our own transcatheter solutions. We know treatment of mitral valve disease is messy and complicated, but this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. Thank you very much.
Thanks for your nice lecture, Dr. Grube. I think it's very different approach, hemi-valve. So it's quite innovative. I think we look forward for your next work. So we will talk, have some discussion time after all lectures. Let's move on to the next talk. Shunsuke Kubo from Japan. He will give a talk, tips of mitral TEER using PASCAL device for primary MR. Shunsuke, please.
Hi, thank you, Zen-sen. So I'm Kubo from Japan. So I talk about the PASCAL device for the primary MR. So this is the PASCAL precision system. You know that we can use the PASCAL device combined of the three catheters, the guide C, steerable catheter, and the implant catheter. And the PASCAL device also has two devices. One is the P10, the PASCAL implant, and another is the PASCAL ACE implant. So this is very wide and very wide. So personally, I prefer to use the PASCAL ACE device in the primary MR. So this is a class 2D randomized control trials comparing the mitral clip and the PASCAL device for the primary MR. You can see that there is no significant difference in the significant difference in the efficacy of the MR reduction in the two groups. But when we look at the MR grade at 6 months follow-up, the PASCAL device had a better durability of the MR reduction, especially in the complex anatomy, the huge frail gap, and also the MAC patients. So the one feature of the PASCAL device is it's very easy to gain the height. It's it's good feature for our Asian patient because our patients are very small heart. So when we turn the guide is clockwise and turn the steerable catheter counterclockwise, so we can make the cobra head shape like that. So when this shape, when we create this shape, so we can gain the height very effectively. So there is a unique feature of the PASCAL device that I think I like the two features of the PASCAL device. So one is a wide power range full elongation system. So this elongation shape is easy. It allows easy and safely positioning without caudal entanglement. And also this is a central spacer and a traumatic class is this implant can adjust for the various mitral valve anatomies. So we now so I'd like to show some cases. This is a case of the P1 to the ACOM prolapse. You can see the eccentric MR from the P1 prolapse. So firstly, we grasp the leaflet in this position, and after closing the implant, you can see some residual eccentric MR just lateral to the device. So we have to go more commissure side. So once we take the device to the left atrium, we go to the left ventricle, this elongation shape. So this elongation shape, it is easy to go to the very exact target of the leaflet. And we check the clocking in the 3D image. So we graph the leaflet like that. After the closing, there is no eccentric MR lateral to the device. So in the PASCAL device, we can do the easy repositioning using the elongation of the diamond shape using the 3D MPR. This is also the P3 prolapse, very huge P3 frame. And this is the first class. But after the closing, you can see some eccentric MRs are medial to the device. So we change the position to the more commissure side, more medial side. So this is the second class. After the closing of the device, there's some eccentric MR from the lateral to the device. So when we look at the clocking in the 3D-TE, there's almost 12 to 6 o'clock orientation. So we go to a little bit counterclockwise clocking. So this is third class. Is a little bit counterclockwise, 11 to 5 o'clock orientation. After closing the device, there is no eccentric MR. So this is in this case, I did 3 times capturing, but this procedure all procedure was performed below the valve. So there is no need to go to the left atrium, so using the elongation of diamond shape. So also the PASCAL device, it is easy to optimize the leaflet insertion. This is another PC prolapse case. So this is first clasp. So after the closing the device, you can see that some insufficient leaflet capturing in the posterior leaflet. So we do the independent clasping like that. So after the closing, the leaflet insertion of the posterior leaflet is much better in the second clasping. So this optimization is also easy in the PASCAL device. So this is another case of non-central MR. The A1P1 bileaflet prolapse is a posterior mark. So you can see the eccentric MR due to the mainly the A1 prolapse, but you can see also the severe mark is the posterior side. So we try to capture by the diamond shape from the elongation maneuver in this PASCAL S device. So I like this diamond capturing for the very huge frail patient. So this is this P2 prolapse case, and also this is a P1 prolapse case. As you can see, the prolapse leaflet is stretched using by this diamond shape clasp implant, and easy to this shape allows the easy clasping with a sufficient leaflet insertion. So after the closing the device, there is no MR. And because there is a mark in the posterior leaflet, so PASCAL device cannot be closed completely like that. But this is a night node frame. It's still moving with a heart motion. But the PASCAL device has a central spacer in here. There's no MR through the device. So this is a very nice feature of the PASCAL device. Finally, I'd like to share the leaflet damage of the mitral clip covered by the PASCAL device. So this is a functional MR. It's due to the ischemic cardiomyopathy. There is a wide central MR from the A to P2 region. So firstly, we try to grasp the leaflet using the XCW device. But after closing, no central MR, but you can see some eccentric MR from the mid portion of the posterior leaflet. So we check the leaflet like that. So there is some MR here. So I put this XTW device that is almost a central part of the A2P2. It's just lateral to the perforated part. So after the deployment of this device, there is no central MR, but you can see some residual eccentric MR from the mid portion of the posterior leaflet, indicating the leaflet perforation of the mitral clip device. So we consider the better strategy for the leaflet perforation. So we consider to put the additional device, the PASCAL or mitral clip. But when we consider the device is a gripper of the retention element position of the both devices. So when we choose a mitral clip device, so this gripper can worsen the perforated part. So we selected this PASCAL S device for the Eberhard strategy. So actually, this is actually the procedure images. So we inserted the PASCAL S device to the elongated shape in the just medial to the this XCW device, and we capture the exact the target of the perforated part. I think perforated part here and the retention element nicely touch the just posterior to the perforated part. So after the closing the device, there is no MR and completely covered by the perforated part is completed by the PASCAL device. So this is summary. The complex mitral anatomy, such as commissural lesion and calcification, can be safely and effectively treated by the PASCAL device. I think the elongation maneuver, the clasp design of this device, enabled to grasp the leaflet very accurately. Thank you for your attention.
Thank you, Dr. Kubo, for nicely introduce the unique feature of PASCAL device. Thank you. And our next speaker would be Dr. Takashi Maruro. His topic he was to introduce us the tips of intraoperative imaging for mitral TEER by 3D TEE.
Good afternoon. I'm Takashi Maruro. I'm honored to be here today, and thank you for allowing me to give this presentation. And I'm an imaging specialist in Kurashi Central Hospital in Japan. Today, I'd like to talk about tips of intraoperative imaging for M-TEER by 3D TEE. Now let's move on to the presentation. The first tip is don't miss indentations, and the second tip is recognize the complex anatomy. The first tip is don't miss indentations by 3D TEE to avoid SLDA. I will present a recent case. This is our early case about 7 years ago. M-TEER was performed at the other hospital, but the severe MR remained. The first device was implanted in medial A2P2. You can see severe MR from A2P3 indentation because of distortion due to a first device. The images were not clear due to our early cases. We implanted the second device in P3 near the indentation. In the left, the second device appeared to be grasped the leaflet, though the leaflet insertion was not well verified. In the right, MR was reduced or trivial. P3 might be grasped on 3D and MR reduced. However, the device was released, the posterior leaflet was detached, and the MR between P2 or P3 became severe. From this case, we learned the tips that don't miss indentations to avoid SLDA. The SLDA of M-TEER near the indentation usually means that the leaflet slips laterally off the device. If the leaflet on the device is less than the width of the device, or like a red square, devices might not grasp leaflet completely. However, it is impossible to evaluate the width of the leaflet on the device by TE because echo beams have width. Therefore, if you try to implant devices near indentation, careful confirmations are essential by 2D TEE and 2D TEE as well. The following is a case who were treated using the tips. LVEF was 30% due to OMI. Ventricular FMR from entire its piece, but RMR are divided into medial and lateral. You can see a gap and a larger MR in medial its piece. The main target was the medial MR. This is a 3D image. You can see indentation. You can see indentation in the middle of the piece. So here is a zoom 3D image. You can see the indentation clearly. The right is from LV. The depth of indentation appears to be clearer. Here is the color explain and 3D image. We thought we should grasp the medial piece placing the device in the middle of the MR jet like the red line while avoiding the indentation. Indentation is here. The mitral clip XT device was in the middle of the medial MR jet. Reflector insertion was very good. 3D image compared to left is a preoperative image. Compared to the preoperative image on the left, the device was accurately guided to medial P2. When closed, MR decreased to trivial. MR on lateral side was also reduced. The second chip is recognize the complex anatomy by 3DT for non-central MR, as Dr. Kubo presented. A volume rendering image by 3DT, as shown, helps us intuitively understand the complex anatomy of non-central MR. It is useful to identify each leaflet and indentation surrounding commissure regions. Here is the case of non-central prolapse using VR. Biplane images show A1 prolapse with a tendon rupture and eccentric jet. VR by 3DT image shows the prolapse surrounding anterior commissure and eccentric jet from lateral side. Here is the 3D image. You can see A1 prolapse with tendon rupture and the small A commissure and a P1 prolapse. Then we plan to insert the catheter between A1 and P1 and grasp them like the red line. So moving on to the treatment. On the left, our PASCAL S was placed in A1 P1. Reflector insertion was very good, and we done the grasp. On the right, when closed, MR decreased to trivial. The orientation of the device in A1P1 was almost straight as planned. After releasing the device, there were trivial MR. Multiplanary reconstruction, M-TEER allows us to create ideal cross-section images by setting angles and locations freely, as you know. M-TEER, in addition to VR, is useful for non-central prolapse because it can help us make precise plans for the complex anatomies. Next is the A3 P3 prolapse, our case using M-TEER. Biplane images show the P3 prolapse with a tendon rupture on the left and eccentric jet on the right. VR 3D TE images show the S3PC prolapse and the eccentric jet from medial by 3D color image. Here is the zoom 3D images. You can see our S3 prolapse and the P3 prolapse with our tendon rupture. We planned the strategy by M-TEER in the case, as Dr. Kubo shown in the before presentation. We plan to insert the catheter between medial S3 and P3 and grasp them by the first PASCAL S, like red one, more medial side, and then we would grasp the lateral A3, P3 by the second device, like the red line. Moving to the treatment, we could guide the procedure by good M-TEER image in the images. In this case, the leaflet were on a diamond-shaped device. The orientation was in 11 to 5 direction of VR image. Then we confirmed the leaflet insertion and down the clasp. The leaflet affixed well. MR from medial S3P3 disappeared, but MR from lateral S3P3 was left. So the second device was in the lateral S3P3, just next to the first one as planned. The leaflet insertion was confirmed. We put the clasp down. We closed the second device. MR was trivial after releasing the second device. There are the final 3D images. MR was trivial, and 2 devices were fixed well. Yeah, here is a take-home message, and don't miss indentation by 3DT to avoid SLDA. Recognize the complex anatomy by 3DT for non-central MR. Thank you very much.
Thank you, Dr. Marullo, to introduce how to wisely adapt the 3D image for the procedure to treat the commission and also the indentation MR. Thank you. So I would like to introduce our next speaker, Dr. Joon Bum Kim from Korea. He will present how to the minimally invasive SAVR update in Asan Medical Center.
Thank you for kind introduction. I'm so much excited to share our institutional experience in surgical aortic valve replacement. And when I review the entire program, this is the only chance to share any surgical treatment in this meeting. So I'm pretty much pressured to show the best picture of surgery. So I have no disclosure. I know a vast majority of the audience are cardiologists, and I believe you like this picture very much. Whenever you talk about the surgical aortic valve replacement to the patients, you convince TAVR over surgery because the surgery is so much bloody, messy, life-threatening procedure. And after all this procedure, you come to leave this very ugly incision, and you have to be pretty much unstable up to several months after surgery. But in reality, in Asan Medical Center, we are moving toward a little bit far more convenient and less invasive approach like this. It's usually involve 5 to centimeter incision on the intercostal approach without cutting any ribs, and you can get access to the aorta. And maybe Dr. Hosoba from Japan may have a smaller incision down to 3 centimeter using thoracoscopic approach or robotic approach. So we have a bunch of other options, and these approaches usually remain only very small incision, almost near to TAVR incision in the femoral. Nowadays, we have 3 major options of full sternotomy, upper mini sternotomy, and right mini thoracotomy. Outside of these procedures, we have several more options like robotic or endoscopic approach, but I believe these are 3 major approaches that are used in the real clinical practice. This picture I had shown you last year is entailing up to 2020 data, and I was asked to share the more recent data in this meeting. So before sharing our very recent data, let me the study on updated published literature to see how the minimally invasive approach impacted on our usual patients. This is the largest meta-analysis that compared between the standard sternotomy and minimally invasive approach. In this particular study, the authors enrolled these two approaches using only randomized trials because there were no randomized trial using thoracotomy approach. So in this paper, there were 14 randomized trials, including over 1,300 cases in the study. When you see the results, cardiac ischemic times were longer with minimally invasive as expected, but early mortality did not differ between the two groups. Meanwhile, hospital stay was shorter with smaller incision, and blood loss was less with minimum incision, and pain score tend to be lower with smaller incision as expected, and quality of life tend to be better with minimal incision. And that's the best evidence that I identify from the literature. But what I am more interested in is the much smaller incision than this. This does not involve any resection of the bones, and then when I do this, the bleeding amount is pretty smaller than prior to sternotomy incisions. And this is the largest and then most reliable data that I find from the literature. In this particular paper, 10 centers in Italy and Germany collaborated to have a large observational data involving almost 6,000 cases. The data was so sound that it had almost 3,000 of sternotomy and 1,700 of upper mini sternotomy, and also 1,000 of cases of RAT approach were available in this study. So over time, the minimally invasive procedure was prevailing significantly, and baseline profiles were naturally kind of biased because of the practice pattern, but they used the propensity score matching, yielding almost 2,200 pairs of patients. And within the mini surgical AVR, there are a mixture of thoracotomy and upper mini sternotomy patients. The baseline profiles are well balanced by the propensity score matching, and after matching, outcomes are like this: intraoperative variables indicating that minimally invasive surgery required 5 minutes longer duration of a procedure, as is shown here. But most importantly, low cardiac output syndrome and 30-day mortality rate was significantly lower with minimal incision, with 40%, almost 40% reduction in the 30-day death rates. More interestingly is that there were surgeon biases and then hospital case volume dependency in surgical mortality, in that there is an inverse relationship, as expected, between the hospital volume and mortality. And these were also similar to the surgical case volume as well. But when you take a detailed look at this, mini AVR has very consistent low surgical risk, independent of a hospital case volume. And when you break down the practice down to individual surgeon level, the mortality rate seemed to be pretty more stable with mini AVR than full sternotomy AVR. And then let's move to our own data from Asan Medical Center. So last year I showed up to here, and this time I added up to this year, half of this year. So before the medical crisis by the prior President Yoon, we have seen a rising tendency of surgical AVR as well as a rising tendency of smaller incision. Red is right mini thoracotomy, and orange is upper mini sternotomy, and full sternotomy is disappearing. So right now we have done over 70% of mini incision of the entire surgical AVR. Aortic clamping and cardiopulmonary bypass times were pretty similar across the three different modalities before 2020, and it remained similar after 2020. And you see a little bit getting faster procedure time than before with mini incision. 30-day mortality has not changed over the course of 25 years, and the minimal invasive remained very low at 0.3%. And when we take a focused look at the very recent 5 to 6 years experience, the percentage, proportion of right mini thoracotomy has increased from less than 20% to 52%, and this is the major prototype. When you break down the practice to the individual surgeon level, there are 4 large volume surgeons covering almost 70% of the entire surgical volume. Surgeon A is the youngest one among the 4 and started with sternotomy, but he had very small number of sternotomy and moved to upper mini and right mini thoracotomy. And Surgeon C has remained stable with the full sternotomy approach, and there are 2 mixed surgeons. So Surgeon A, who spent a year of a sabbatical and had a small number of volume here, had over 90% of minimally invasive surgery. In the meantime, the younger generation surgeon joined this practice pattern that covering up to 70% minimally invasive surgery in Asan Medical Center when it comes to isolated surgical AVR. In this particular surgeon, aortic clamping time, procedural time was much faster with full sternotomy, but the minimal incision was still excellent, faster than average surgeon's full sternotomy. And the trend transferred to the young surgeons with a very optimum level of procedural time. And then baseline profiles are like this. Interestingly, the mini incision patients had greater comorbidity with older ages, greater proportion of diabetes, dyslipidemia, ESRD, and chronic lung disease, and there was a pattern of surgical years. We tried to match the patient by propensity matching, and we enrolled very balanced patients of 281 patients in each group, and in the matched cohort, the procedural time was significantly longer with a smaller incision than conventional incision. But after adjustment, before and after adjustment, the outcomes were pretty similar across the 3 different approach. But because of the time limitation, we could not yield any quality of life assessment or pain score. But when we study from our data on aorta surgery, which is more challenging and complex surgery, we have moved from here to replace the entire arch. And in this particular paper, we have seen that the major adverse outcomes were reduced by mini incision with the statistical significance, and the pain score during hospitalization was lower with upper mini sternotomy, and hospitalization was shorter significantly by the small incision. So I strongly believe that small incisions also works for surgical AVR as well. So minimally invasive surgical AVR is increasing worldwide as well as in Asan Medical Center. Despite high surgeon-dependent variation in practice pattern, large-scale analysis indicate that minimally invasive surgery is associated with reduced transfusion, short length of stay, better quality of life, and less pain. And Asan data seems to go well with these recent findings with promising results. Thank you.
Thank you. Thank you, Dr. Kim's update on minimal invasive SAVR from Asan Medical Center highlights how surgeon innovative can achieve excellent outcome. So thank you. So our next speaker will be Dr. Takao Morikawa, and he will give us talk about mitral TEER after surgical mitral valve repair.
Okay, thank you, Adam. So I'm a little nervous to make this title because after the surgeon's presentation, but yeah, let me start my presentation. And this is disclosure. So, and also I mentioned about the mitral regurgitation and recurrence after mitral valvoplasty. The pattern of recurrence after membraplasty has a variation. Leaflet issue like recurrent prolapse or leaflet scissoring. and ring issue like ring detachment, and also the other reason. So this means recurrent MR has a heterogeneous morphology. So to face this mitral regurgitation, and we have two options so far. First thing is M-TEER. Second thing is TMVR. But both of the procedure is complex procedure because of the complex anatomy. And only M-TEER is approved in Japan. So I'd like to focus on M-TEER after mitral valve surgery today. So this is my talk. So first thing, I'd like to talk about how to assess leaflet behind annular ring. Second, how to avoid mitral stenosis, and also tips and tricks. So first thing, I'd like to talk about the posterior leaflet issue. What is posterior leaflet issue? So as you know, it's already reported, after ring annuloplasty, posterior leaflet tethering get worsened. And also, from TEE, it's difficult to find posterior leaflet because ring hides the leaflet like this. So how do you make sure the posterior leaflet? This is the answer. Use TTE. From TEE, there is an annulus ring in between TE probe and posterior leaflet, but there is nothing in between posterior leaflet and TTE. These two images are from the same patient. From TEE, it's hard to make sure posterior leaflet. So I'm not sure this patient can be treated by M-TEER, but from TTE, you can make sure posterior leaflet, and it looks enough to grasp with M-TEER. And next question is how to grasp the posterior leaflet which cannot see. So, and my answer is just dig from a shadow. If you can make sure the posterior leaflet from TTE, so there, certainly there is a posterior leaflet behind the posterior ring, like this. And I call this is digging technique. So just dig. After digging, there is another problem. So leaflet insertion assessment is also difficult from the shadow from posterior ring. As you can see, it's hard to make sure the posterior leaflet insertion. In such case, fluoro is useful. Like this. As you can see, if the leaflet is under gripper is dancing under fluoro. So these findings would help to achieve the procedure success. And next talk is how to avoid mitral stenosis. And this image shows a correlation between ring size and pressure gradient after mitral annuloplasty. So the smaller the annuloplasty ring size was placed, the higher mitral mean pressure gradient is increased. And also, even if you place the annuloplasty ring under 30 millimeter, full ring has significantly high mean pressure gradient post-procedure. So this means smaller size and full ring resulted in high mitral valve pressure. So let's move on to the case. This patient is status post mitral annuloplasty for ventricular FMR using 27 millimeter full ring. Mean pressure gradient was 4.7 and the MVA was only 2.68. But TMVR is not suitable and we cannot do TMVR in Japan, so we decided to perform M-TEER using mitral clip. First, we grasp we grasp right in the middle with mitral clip NT. It resulted in the mean pressure gradient increase like to 6.9 millimeter mercury. Then we move to more lateral to keep the medial orifice bigger. After grasping, mean pressure gradient decreased to 4.5. So I think this is acceptable. And this patient have already been implanted biventricular, dual chamber pacemaker. So we assess the mean pressure gradient with changing the pressure, his heart rate. In heart rate 70 BPM, mean pressure gradient looks acceptable, like 5.1. And if we increase the heart rate until 290 BPM, mean pressure gradient looks still 4.7. So we think this is acceptable, and we decided to deploy the clip. So clip location is important in case with smaller ring. And the assessment with changing the heart rate is also useful to avoid the mitral stenosis. And last is tips and tricks. And this is the case of ring detachment case. Actually, this is not our surgeon's case. And as you can see, there is a detached mitral valve annular ring, and it's moving to forward and right above the mitral valve. So this means it's hard to advance the clip directly. So in such case, intentional out-hugger is useful like this. And next case, this is also not our surgeon's case, and this case shows this is the SAM case, systolic anterior motion case after the mitral valvoplasty, like this. The mitral TEER is a good option also for mitral, also for SAM case after mitral valve repair. As you see, the pressure gradient looks decreased, and some is also improved. And this is also not our surgeon's case, and this is a deferred case for our hospital. This patient has recurrent mitral stenosis after myoplasty and presented hemolysis. As you can see, recurrent mitral regurgitation is hitting to annulus ring. So then we try to put the mitral clip there, and as you can see, the eccentric jet hitting to annulus ring is disappeared. And this is a patient. this is a pre and post patient's blood test. As you can see, hemolysis is improved. So this is conclusion. M-TEER is good option after mitral valvoplasty, and if you cannot make sure posterior leaflet, TE is useful. If you can find posterior leaflet with TE, just digging. And clip location is important to avoid mitral stenosis. Thank you so much for your attention.
Thank you, Dr. Morikawa. Thank you for the challenging cases to rescue the recurrent mitral regurgitation after surgery. So any question from the panel?
So,
yeah,
please.
I would like to have a question for Takao. You mentioned the mitral valve remain area will be very crucial when you reposition the clip. And what do you think about will PASCAL be more forgiving on mitral valve area in treating patient in such condition?
Yes, so everybody thinking PASCAL device has a benefit to reduce to increase the residual mitral valve area, but personally I don't think so, because it just depends on the device size. So mitral clip MT is the best device, and when you look back to the COAPT 2D data, there's no difference between mitral clip and PASCAL devices regarding to the pressure gradient post procedure. Yeah.
Thank you.
So I have a question for Professor Grube. So we can see that M-TEER now is actually very well performed internationally because of its reproducibility and also safety. So you just now you present a different way of mitral valve repair technology, but none of this include the previously performed percutaneous annuloplasty. So is there a reason, or you think this technique is already fading out, not getting into favor?
Well, obviously there is a reason, because we couldn't do it, at least until now. And that has several reasons. The surgeons can look at it by minimal invasive or whatever approach they're taking, and they're suturing this, and this is a, I don't know, a 10-minute at the most procedure. It's an additional procedure to stabilize the annulus, which is lacking in our approach. Whether or not that has an impact on the results of M-TEER, it's speculation, but at least in the long-term result that we learned by surgery, stabilization of the ring is essential to get good long-term outcome. I think what we see now in TEER, and you said it, it's a very safe procedure. That's why I think we have to pay tribute to the technology, no question about it. The question, though, is once you have a failure, as with any failure after surgery or transcatheter, the left ventricle suffers. It is not like the situation before M-TEER or surgery. If the two approaches fail for whatever reason, the ventricle is not recovering, it's not remodeling. Remember, remodeling is something that impacts long-term outcome. In M-TEER, in COAPT, even in Gen 4, there's no negative remodeling. Why that is, it is open to discuss, but it is very important that we, number one, don't interact too late, and number two, that we really reduce mitral regurgitation to less than minimal. It's not enough to just get 2 rates down. And that is a big difference, that the situation before treatment, both for surgery and for M-TEER, is not the same after failing, because the ventricle suffers, and the ventricle might, and that's what we are seeing, not so often, but we do see it. If we take the clip out or cut the clip, and we remain percutaneously and put, at least in Europe, you put a Tendyne valve in, then the ventricle has all of a sudden to deal with increased afterload. And some of the ventricles simply can't handle that because they suffer too long. The patients are feeling better, but when the ventricle dilates too much, then the patient feels it. And then the patient comes to control, and then we are struggling with a bad ventricle. Putting a valve in is not actually the best solution. So I think it is a very complex situation, but we have to be, I think, we have to be open to other solutions. I'm not discarding M-TEER. Either we have to do it earlier and have, control the patient, much rather than doing it too late. And that holds for surgery and for transcatheter approaches.
So yeah.
Sorry.
Go ahead.
So a question for Dr. Grube. Yes. So my question is for the hemi valve. All the valve is posterior mitral valve leaflet. So is there any new idea on the hemi valve involving the anterior mitral valve leaflet?
Yes. To make it very brief, I only presented the ones that are public domain. So I didn't want to break any confidentiality, but as you can imagine, when interventional cardiologists are impatient and we try to move forward. The TAVR journey was such a big success that we tried to duplicate this on the mitral space. But unfortunately, it didn't happen. We had setbacks, and we scratched our head and said, well, we tried annuloplasty, but until today, all of these devices disappeared. Now, there are 3 more early approaches. The problem is that the surgeons can suture it under vision. minimally invasive or medium sternotomy or whatever approach they're choosing, but they can suture it. We cannot suture it. We have to screw the valves in, and screwing a valve in a moving target is extremely difficult. And we all know the results on the devices that used screws. They all disappeared because over time the screws came off due to the milking of the annulus. That makes it very hard. The Polaris approach, using a central screw and 2 lateral screws, are holding. Why that is, not quite clear. That is at least an optimistic sign. But the surgeons have the advantage to suture it. We can't do that. So our approach is anchoring into this moving target, and that is very, very difficult, and so far has not been successful. The indirect approach, the Carillon, as you all know, is using the coronary sinus as an indirect approach, approaching the posterior to the anterior. But other than that, we don't have anything, and then comes the clip. And the clip is, as I said, is brilliant. It changed our view, but like with everything, is this enough? And by the way, we compare the edge-to-edge therapy, and it's a bad description of what we try to achieve. Why is this procedure called edge-to-edge? Because it approaches the edges. It doesn't increase coaptation, what we would like to see. So there's a lot of reasoning behind. And when Dr. Alfieri used this approach many, many years back, he used that approach, the Alfieri approach, with stabilization of the annulus and then with a stitch, reducing the orifice and stabilization of the annulus. So it's a little bit, it was an emergency procedure then, but it was fairly straightforward, fairly simple. It didn't need any specific talent or skill set of the surgeon. It was pretty straightforward. The first 200, they never published it, unfortunately. Now we regret this because they did stitches without annuloplasty and stitch with annuloplasty. And the long-term results without annuloplasty were much worse than with annuloplasty. So this is something that we have to think about. And my point that I'm trying to make is we have to, if we follow the surgeons, on the aortic space, it's a lot different. But on the mitral space, we don't even come clear. And I'm talking about experienced surgeons. We all know that repair is a matter of experience and skill. Not everybody can do it. There are specialized centers, not only here in Korea, but also in Europe and America, that can do a good job. Not everyone can do it. I accept that. But if we trail behind and do what the surgeons did or are doing, then I don't think we will be successful. I think we have to get out. Remember, when we first started TAVR, that's why I put this at the very beginning, nobody believed in us. We didn't get the funding because everybody said it's a crazy idea. You cannot do that. It's dangerous and you're going to end up in prison. If we trail that, then I think we will not be successful. That's why I think the hemi valve leaves options open, at least in the early stages, and Polaris has done about 80 patients now with really good long-term results. Half Moon, supported by Medtronic at the time when they supported the technology, was in part successful. The concept worked. There was an anchoring issue. And then the Sutra, the tri-leaflet, they did the first in humans, again, anchoring problems. So anchoring is very, very important. And unfortunately, the materials, basically using nitinol, unless you have a very, very high grade of nitinol, it fractures. And we don't like to see this. And that's where we're looking. I myself have founded a company, a mitral company, that it's too early to talk about, but hopefully next year, if I'm still alive and invited, I will give you some some update on it. But I think this is an interesting approach because it really does not mimic what the surgeons are doing, at least not surgically, but it coapts and forces the anterior and the posterior, the artificial valve, to coapt in a range of 6 millimeters. And I think that's an important step and leaves future options open.
Thank you.
Sorry about the long
Thank you for nice sharing. And because of time, we need to close the section and welcome to the next section, the moderator.